Hi everyone, welcome to week 4. This is going to be about communicable diseases and skin conditions in the pediatric patient. Learning objectives, compare clinical manifestations, pathophys, clinical treatment, and nursing management of common viral infections in pediatric patients. Compare and contrast communicable diseases, rashes, and allergic reaction rashes. Discuss how to treat communicable diseases in the pediatric population. So the communicable diseases that we are going to be talking about today are varicella, rubeola, rubella, mononucleosis, which I know we covered a little bit last week. We'll just do a brief overview and maybe add a few more pieces of information today, and then scarlet fever. So we're going to start off with varicella chickenpox. Chickenpox is a very common childhood disease until they developed the vaccine years ago, not too long ago actually, in the history of vaccines. It's the more relatively or newer vaccine. This virus also causes shingles in adults. It's spread mainly through the respiratory tract with droplets. So when someone coughs or sneezes, those droplets go into the air and they can get into another person's respiratory tract and cause an infection. They can also be caused by skin lesions. The skin lesions slough the virus, and any contact with that or close contact inhaling those droplets or the virus from the lesions can also cause infection. So spread can be caused by direct contact, like I said, with the lesions, droplets through the air, and also it can live on objects. So the droplets and anything that touches the skin lesions can hold the virus and can cause and can be communicated and cause the infection. So contaminated objects are also a way to get the infection. So when are you infected? When can you cause the infection? One of the reasons why this is such an infection that spreads very quickly is because the person is contagious one day before lesions erupt, and about 6 days after the first crop of vesicles, and then they are contagious until all the vesicles are crusted over. So these patients need to stay in isolation, stay away from other patients until all other vesicles are crusted over. But before they even have an eruption, they will be contagious. So there's a reason why this disease can cause or can spread very quickly, especially among kids, because they're in close proximity and they don't even know that they're infected until it's too late. So manifestations, symptoms of chickenpox. Non-specific symptoms or symptoms that are pretty general include fever, malaise, or lethargic, just a little lethargic kid who doesn't feel like playing. They have swollen lymph nodes. They don't feel like eating or drinking much because they're not feeling very good. And then you get the itchy rash. The itchy rash makes them very irritable, and they just are uncomfortable. So the rash begins as a macule and then progresses to a papule and then a vesicle, and that vesicle erupts. The rash is usually in the central spaces. Distal limbs and areas exposed to heat are spared, so that is mostly in the trunk area. The dangerous part of chickenpox is that it can get into the throat, especially in older children. As you get older, the severity of chickenpox becomes worse, and you can get in their throat. It can cause respiratory compromise if it's a very bad infection. So that's just something to be aware of as children get older, and if they get that infection later on in adolescence or young adulthood, it can be more severe. So this is what your rash is going to look like, as you see on the macule to papular rash to vesicle, and then the vesicle erupts. This is a severe case of chickenpox for this poor boy. Has him all over his back. So probably very, very uncomfortable. Management, antiviral treatments, they can be somewhat effective. to a certain extent, but usually, again, you have to get those antivirals in pretty quickly for them to be effective. Varicella IVIG, or immunoglobulin, can be administered. This is a passive type of immunity. So this immunity lasts for a short period of time, is not used in general, is used mostly for immune compromised patients who were getting chickenpox can be fatal to them, or it can just cause a lot of morbidity. Supportive measures for these patients, giving them Benadryl or an antihistamine for the itching. Preventing secondary infections by helping them with their itchiness, using baths or skin lotions that can help them from being too itchy and relieve their itchiness so they don't scratch too much and cause those secondary infections. And of course, we're going to give antipyretics for fever. Includes Tylenol, ibuprofen, whatever parents have available for fever. Complications. So varicella complications, secondary bacterial infections. Like we said, time you have someone itching at a rash, you're going to have a possibility of a secondary bacterial infection. So preventative means helping relieve their itchiness is important. Another complication, which is rare but does happen, is encephalitis. Sometimes pneumonia, again rare in children, but can happen. More common in the adolescents, young adults who contract chickenpox. Hemorrhagic varicella, also rare. Chronic or transient thrombocytopenia, so they can have a short period of time, acute period where they have thrombocytopenia, or it can last for months after the infection. How do we prevent? Well, primary prevention would be with immunization. So we do have the varicella zoster vaccination available to children. So that helps to create immunization. And also secondary prevention would be to, if you do have a child with chickenpox, is to keep them isolated and away from other children so that they can't infect other children. So the kind of relative of varicella zoster is herpes zoster, and this is actually the varicella zoster that has been reactivated. So what happens is once someone gets infected with varicella zoster, it becomes dormant in the nervous system, and it's not contagious, but during times of stress, immunocompromise, or as you get older, you have a higher risk of this virus causing shingles. And you can also get chickenpox from people who have shingles because it is the same virus as chickenpox, but it has just this time causing shingles instead of chickenpox. Shingles. So as you get older, like I said, your incidence or risk of getting shingles increases. If you're immune compromised, that's why we talk about it in children, because children that are immune compromised have a high risk of getting shingles. It is contagious to anyone who has not had varicella. Again, so anyone who has not had the chickenpox, this is contagious for. If you've had the chickenpox, it's not contagious. Or if you're immune suppressed, it can also be contagious. So what happens is the virus sits in what they call a dermatome, and we'll look at a picture in just a section. It sits in a dermatome when it goes dormant after it causes the initial chickenpox virus infection, and it will distribute along that dermatome. It's a very painful neuralgia that happens right before the outbreak, and then the outbreak is like a chickenpox, but it's only along that one dermatome. And you can give antivirals for this if you do catch it in time within 72 hours. It might help prevent the nerve pain associated with it. Again, it is a very, very painful disease. So if you do have shingles, or if you have a patient has shingles, pain control is going to be very important for this patient. The Shingrix vaccine is available for adults who are 50 and older to prevent shingles, prevent that chickenpox virus to express itself as the shingles. So here's a pictures. Again, you have the dermatomes here where you have, they show you where the virus could sit. And as you look in here, you can see on this little boy's arm, he just has it from his right side sternum all the way up his arm. And that's going to just follow that one dermatome that the virus has hidden in after it caused the chickenpox. And again, on the lower picture, you see this is an adult who has just that one single outbreak. It looks like that linear line, and that is just following the dermatome in which that virus was living in prior to infection. It does not usually happen again, but it can. Shingles usually is a one-time disease, and then they won't get it again unless you are immune compromised. But you can have a reinfection, but it's not very common to have the reinfection. Next, we're going to talk about rubeola, also known as measles. Rubeola is caused by a virus. It's found in your respiratory tract, blood, urine of an infected person. It is spread by direct contact with droplets of that infected person. So it's a respiratory, or if they have contact with that blood and urine. It's contagious. Again, the problem with rubeola is that it's contagious before you actually see some of the more classic symptoms of the rash. So 4 days before a rash and up to 5 days after the rash, a patient can be contagious. Something that we need to keep in mind when we are treating the patient if they are in isolation. And also if they go home, you have to let them know that they will continue to be contagious 5 days after that rash. So here is just a little boy who unfortunately has measles, telling you what the early symptoms look like. Develop 10 to 12 days after being exposed, fever, runny nose, sneezing, sore throat, anorexia, diarrhea, so there can be abdominal symptoms as well. And they last about 3 to 5 days. And after that, they have this classic Koplik spots. So Koplik spots are indicative of measles or rubeola. They appear on the buccal mucosa, and you can see them about 2 days before you get the rash develops. And then you get high fevers up to 104. The rash will last about a week. There are only complications can include encephalitis, severe diarrhea, dehydration, respiratory complications. So those are things that you need to watch out for. Initially, again, we have fever and just lethargia. After 24 hours, they might feel like they have a head cold and they get conjunctivitis. Then they have those Koplik spots, again, that are indicative of measles. And then these symptoms will increase in severity for about 2 days before that rash appears. And then a rash appears, erythematous maculopapular rash, and it starts on the face and it spreads down the body. After 3 or 4 days, it becomes brownish in appearance, and then you have peeling. The skin will start peeling. Management of rubeola includes vitamin A. So administration of vitamin A is important, and depending on the age and the size of the patient, the recommended dose. Supportive measures also include bed rest and giving medications for fever or for pain. So antipyretics or Tylenol can be used both for fever and for just basically aches and pains that you have associated with this virus. Antibiotics can also be given depending on, can be penicillin or erythromycin, one of those categories, but antibiotics will also be given to help with preventing secondary infection from this disease. Nursing consideration, so you're going to have that patient on isolation for at least 5 days, but actually in the hospital, you're never going to get them off isolation. There's no point in taking them off isolation and risking them spreading this disease. So we will have them on isolation for the entirety of their hospitalization. You might also dim their lights. They could be photophobic, so make sure they have nice dim lights, cool, quiet room, warm saline for their eyes. They can get crusties in their eyes, so if you just take a little bit of gauze or a washcloth and put some warm water on it and wipe their eyes. That helps to remove the crust so that they can open their eyes. At home, they can do cool mist for vaporizers, cool mist vaporizers for their coughs. Encourage fluids. So if they're eating and drinking, make sure that they encourage you encourage the fluids. If they have IV fluids, make sure that they're getting the appropriate IV fluids. Tepid baths can also be a relief for the itching and help if they have a fever, help bring their fever down. So you can give them tepid baths to help them feel better. Complications of measles can include otitis media. They can get pneumonia, bronchiolitis, laryngitis, or encephalitis is a severe complication. Again, I think we've seen a couple patients that have come in with encephalitis. It just means that the brain is swelling. It's going to affect their cognitive function, going to affect their motor function. So we want to prevent these complications. And how do we prevent the complications is through vaccines. So nursing considerations, again, I went over this. Isolate for 5 days, maintain bed rest in the febrile stage, give antipyretics for fever, clean the eyelids, cool mist for cough, encourage fluids, keep skin clean, use tepid baths for discomfort for the rash. Rubella. So moving on, so we have measles and then we have German measles. So rubella is measles and rubella is the German measles. It's caused by a virus, the rubella virus. Not hard to remember, found in the nasopharyngeal secretions, blood, stool, and urine. It is also spread effectively because it spreads, you are contagious about 7 days before a rash appears, and again 5 days after the rash appears. So pretty much make sure that these patients are isolated for a good period of time. It's also pretty contagious because you are being able to spread it 7 days before you even really know that you have it, before that rash appears. So no symptoms prior to rash in children. Sometimes they will, sometimes they don't. So they could just erupt in the rash before you know that they have this disease. Adolescents and adults, they usually present with low-grade fevers, headache, lethargia, malaise, anorexia, head cold symptoms, having a sore throat, cough, and again, having swollen lymph nodes. Pretty common, non-specific symptoms that we see in a lot of different diseases. So very important to monitor the patients when they start complaining about these diseases, or rather complaining about these symptoms. So here's just a picture of German measles. Again, little pediatric patients, they may not show a whole lot of symptoms prior to getting the rash. You will see mild fever. They might have a sore back of their neck and ear, and they'll have swollen lymph nodes in their neck. You can palpate faint pink red spots. They might be itchy. After a warm shower, of course, they might be more noticeable because that warmth brings out the blood to the surface, and they might have the patches of rashes may peel, and it will fade as it spreads. So it starts head to toe. It'll also fade head to toe. Older children can get pink eye, headaches, again, anorexia and joint pain. So the rubella rash appears on the face and spreads downward to the neck, arms, trunk, and legs. It usually spreads pretty quickly, so by the end of the first day, the whole body is going to be covered. It is a pinkish red maculopapular exanthema rash, type rash. It disappears, like I said, in the order that it began, so it disappears from the face down, and it is usually gone by the 3rd day. So again, it's contagious 7 days before this rash appears. The rash is usually there for about 3 days, and they're contagious for about 5 days after the rash is gone. So important to know that timing when you're educating the patients and knowing how long they need to be kept in isolation. Here, no real treatment is needed, but we will treat the symptoms, and that would include If there's any itchiness or fever or just general uncomfortableness, we'll give Tylenol, ibuprofen, antipyretics, or analgesics that will help treat those symptoms. Rare complications can include encephalitis, but we do need to make sure that we isolate these children from pregnant women. It is tetragenic, which means that it can harm the fetus. So if you have a parent who is pregnant, their child develops rubella, it puts them very a great risk for that fetus. So that's something that we definitely need to be aware of and to educate parents on, especially if they're trying to get pregnant or they're just pregnant. These patients will be on droplet precautions. So we talked about this a little bit in the last lecture, mononucleosis. We call it the kissing disease. It's caused by Epstein-Barr virus. It's kissing disease because it's transmitted by direct contact with oral secretions. Don't know when it's contagious. Don't know how long they're contagious before you actually get it. So that's a little bit of an unknown in terms of when that person who has mononucleosis is contagious and how long they will be contagious for. So symptoms, they can appear 10 days or actually 6 weeks after exposure. So it could be a long period before you actually see the symptoms or any kind of expression of the disease. And the symptoms that you do see they vary greatly. So it could be anything as like something that you can attribute to a common cold, to something more serious than that, a sore throat. So usually the symptoms include being lethargic, not having any energy, having a sore throat, and having swollen lymph nodes. And then, as we talked about, one of the marked or significant findings of mononucleosis is that they have an enlarged spleen. Treatment is symptomatic for the most part. Comfort care, fluids, anti-analgesics, antipyretics if necessary, preventing secondary infection. And again, they will have no contact sports until the spleen returns to normal size, because with an enlarged spleen, you have a risk of rupturing the spleen if they're playing any contact sports. So definitely these are education points for the patients. Here is where you're going to see basically where the symptoms are going to happen. Again, most of them are non-specific. One of the more specific ones is the enlarged spleen, but the other symptoms can be attributed to other diseases as well. So another disease to watch out for is scarlet fever. It is caused by group A hemolytic streptococci. It's caused by a bacterial infection. Basically, it is caused by an inappropriately treated strep infection. So transmission is through nasopharyngeal secretions of an infected persons and carriers. It is transmitted by droplets. There is an incubation period of 2 to 5 days, or 2 to 5 days average, 1 to 7 days total. So it depends on that patient. So incubation period until they see the clinical symptoms can be 10 days to 12 weeks and can last for months. Signs and symptoms: you get a red rash that looks like sunburn and might feel like sandpaper. It begins on the face and neck and spreads to the trunk, arms, and legs. If you push on that skin, it'll blanch, so you'll see like white underneath that red skin, so it's blanchable. Red lines, so you'll have rash becomes more severe under those growing in the armpits or elbows and knees, the place where it's like warmer and more contact with the skin. So you might see more rashes and intense rashes in those areas. A flushed face. You can have a flushed face with a pale ring around the mouth. Strawberry tongue. So at the beginning, the strawberry tongue will look white and then it becomes red as the disease progresses. A high fever, an abrupt high fever is another sign and symptom of scarlet fever, and enlarged tonsils. So again, high fevers with chills, sore throat, difficulty swallowing, enlarged glands, nausea and vomiting, abdominal pain, headaches, and body aches. So generalized symptoms that you see in a lot of the diseases that we've talked about. Complications. So you have complications of scarlet fever can include peritonsillar and or retropharyngeal abscesses, sinusitis, otitis media, acute glomerulonephritis, which we'll talk about later, and also, as we talked about in acquired cardiac diseases, is rheumatic fever. So undiagnosed or untreated or strep infections that aren't treated appropriately, you can have these complications, especially the rheumatic fever and the scarlet fever. Nursing considerations will include they'll be on droplet precautions, and then comfort care, medications, antipyretics, analgesics, and antibiotics, especially to treat that strep infection. So make sure that they know that they need to take the entire course of antibiotics to prevent any further complications from this disease. Torch disease, I'm going to mention torch disease briefly just because I want you to know when we're dealing with pediatric patients, they have families, siblings, they have moms and dads, and a lot of times those moms, if they're younger patients, they might be getting pregnant. So we have to be aware of diseases that can cause illness to pregnant women if contracted. So that's a lot of reasons why we will immunize against these diseases as well, because if they get these diseases and they're around a pregnant woman, it can be very bad for that fetus. It's just kind of good to know what these diseases are. And so we call them the torch syndrome. It stands for toxoplasmosis, which you can get from eating undercooked meat. Other diseases include syphilis, varicella, mumps, parvovirus, and HIV. The R stands for rubella. The C stands for cytomegalovirus, or CMV, and the H stands for herpes simplex. So if you have patients that have these diseases, it's very important to keep them away from any pregnant people. That includes staff that are pregnant, anyone that works in the healthcare system that are pregnant. So know if you have one of these patients that no one that is pregnant or wanting to become pregnant goes into their room or takes care of these patients or has anything to do with these patients. So if they're EVS, dietary, not to go into the rooms. Very important to remember. And that is it for this lecture, this slide deck. If you have any questions, please email me. And that's it.